They concluded correctly that at low-level consumption there was an association with reduced mortality. Similarly, at high levels, like above 4 or 5 drinks per day, there was clearly an increased mortality. But what's strange is that this, published in Archives of Internal Medicine, not a shabby journal by any means, gave this recommendation. I think this was in line with the comment from the audience earlier. Heavy drinkers should be urged to cut their consumption, but people who already regularly consume low to moderate amounts of alcohol should be encouraged to continue. This kind of, I hope you accept, is at the root of this paradox. There are data, there are recommendations, and there are also data and recommendations to the contrary. And so I think this is a fantastic issue for a school of public health with all of the different departments and angles and talents to try to get a grip with. So I'm absolutely thrilled that we finally can surface this issue as an event associated with the School of Public Health and open it to the community so that they can see that our School of Public Health, State School of Public Health, has an interest and motivation to be working on this issue. Now some of the additional bad news. Many people consume alcohol freely. At the same time, they're worried about the cup it's in because the cup might release a molecule of bisphenol A, which might cause some cancer or something, yet the contents are inherently carcinogenic. International Agency for Research on Cancer, 2012, reviewed all carcinogens, all known human carcinogens, alcohol among them. And this time they went back to say, for which cancer sites can we conclude alcohol causes these cancers? These 7 are part of the ones they came up with. I'll just touch on 2 of them, larynx and female breast, to show you some of the affirmative evidence that shows clear associations between alcohol consumption and cancer risk. This one's laryngeal cancer. It's also a meta-analysis, so this is pooling data from a lot of studies, and this shows several curves, all of them going from the least amount of consumption per week to the most alcohol consumption per week. The risk is the odds ratio for laryngeal cancer, and the different lines indicate categories of smoking. So the very bottom line is this, and note the scale, this is a 20-fold, roughly 20-fold multiplier of risk from here to here. It goes up, but it still goes up a very little bit among those who are non-smokers. But look at those who are heavy smokers. And I don't know what these grams per week translate into, but you don't have to go too far below the second line here to reach multipliers of 30, 40, 50 times the rate of laryngeal cancer that of never smokers or drinkers. So I'm adding this, I picked this example because it's inherently complex and it has some interesting aspects of the relationship between 2 exposures. We, especially epidemiologists and biostatisticians as well, tend to try to isolate the effects of one risk factor and hold everything else constant, and that might be a mistake. This is an example of where that's a mistake, where there's a real relationship between the 2 and a synergy. Female breast cancer, look at the striking relative risks with increased alcohol per day. This is grams per day, the other is grams per week, but they're roughly the same scale, so same kind of increase in dose response with increasing consumption. So why do we have this profoundly positive evidence supporting carcinogenicity, yet we also have clear evidence of 20% deficit of mortality, or reduction in mortality from all causes for those who consume up to 4 drinks per day? Here's part of the explanation. Notice the size of the slice of the pie in the upper right corner. For both men and women, heart disease is the biggest category of cause of death. And so to have an impact on that will have an impact on overall population mortality. Look now, cancer is a similarly sized slice of the pie, but cancers are hundreds of different diseases with different etiologies, with different causal factors, risk factors. We look at this from cancer statistics for men and women. I've underlined only these 4 out of the 7 cancers that IR considers known to be caused by alcohol consumption. So the alcohol-associated cancers are a relatively small proportion of overall mortality. And when you put these things all back together into that first graphic that I showed you, it's the cardiovascular disease association that's driving the overall mortality, and that the overall mortality, interpreted loosely, could be quite misleading, especially for any one of those cancers that I had shown. And so I don't want to ignore that there are many, many more problems than the chronic diseases among an aging population. But I do find the science underlying those issues quite interesting. They do have a role in the public health of an aging population, especially those of us in the baby boomer generation, and where clearly there are dilemmas, even on a personal level, of how much should I consume if I do consume alcohol. What are the risks? What are the benefits? These things can be explored and understood scientifically, but ultimately have to be decided individually. So I think the next phase is a panel. I'll just throw out more questions because I don't have very many answers. I think much of what I enjoy about epidemiology is the paradoxical. We have many, many examples of where we just don't get it, we don't understand it, things don't make sense. Our studies say one thing, our personal experience might say another, or just from study to study we see different findings. Is this reality? Or are we just not that good at what we're doing? And I think it's more the latter. I think we've got a long way to go in understanding these complex relationships and looking at risk factors simultaneously. So I think we're more than just what we might consume in one day, whether it's a food substance, whether it's an alcohol, whether it's an exposure at our workplace, or whether it's how far we walk in a day. It's some constellation of those things. And our methods aren't so good so far at addressing those. So essentially what I say in the second point, what we see at a macro level may not be accurate for any one of the elements that go into it at the micro level. And the interrelationships among those are very difficult to understand. And it's great when we try to find science that supports policy and regulation. It's tough, though, as soon as it gets complicated. EPA has been struggling for decades on how to deal with mixtures of chemicals or exposures in the environment. The methodologies are not sufficiently developed to convince legislators using those methods. Finally, I think it comes back home to us. We're a school of public health. We're in a community that has many, many resources. It's a vibrant community. It's got a lot of smart and well-educated people. Yet we've got some pretty basic public health issues right here. And so I would love to see more discussion with the school, with the community. I'm extending the community beyond the school through the rest of the university community, but into the towns surrounding us, because we are an attractive site for adults and young people to come for weekend enjoyment and all. And how people make their individual decisions, I think, should be influenced by what the science says and what the public health community is able to communicate in an accurate way. And that's our role. I mean, we need to be present, and I'm glad that we are. I think it's a great step forward, and thanks to Dean Allion for being persistent on getting this out into the community today.